The recording is now on. Now, with housekeeping out of the way, we hand the floor over to Dr. Sue to begin today's deep dive.
Thank you so much, Janice. Hello, everyone. I am really excited to have you all here today. There are some old faces, old friends, but also some new faces, and we're always very excited to see our new faces and new people joining us here in the Total Care Program. So the Total Care Program at UT Southwestern is a supportive care program for our patients and care partners, but also really all of the Dallas-Fort Worth community. And we're doing multiple things, but a big one is our educational programming. We do virtual deep dives. One of them is here, that we're doing today. But we do these quarterly. I send out information. You can access information about these virtual deep dives on our events webpage. And my focus always is really trying to get the word out so more and more people can join. So I'm hoping you all will go back, enjoy this, and learn and go back and talk to your families and friends about this as well. We also do some programming that's sort of in person on campus. And our next one is a big one with the Parkinson Voice Project. In October, I will send out that information. So welcome you all. I'm going to now introduce Dr. Karen Brewer-Mixon. She is a licensed psychologist with the Texas State Board of Examiners of Psychologists. Dr. Karen Brewer-Mixon is a clinical neuropsychologist here at UT Southwestern, and she currently serves as program director for the PhD program in applied clinical research. Her clinical responsibilities include psychotherapy interventions with persons who suffer from neurological, psychiatric, and functional disorders, as well as neuropsychological and psychological evaluations and clinical supervision of psychiatric residents in a psychiatry residence elective. Psychotherapy for functional neurological disorders. Dr. Brewer-Mixon's research centers around neuropsychological assessment and outcomes for clinical populations. She is involved with many projects, including the Total Care Project here with Parkinson's disease and with functional neurological disorders and various other neurological disorders. Dr. Brewer-Mixon is also a care partner to her spouse with Parkinson's disease. And I am really honored and very excited to have you here today, Dr. Brewer-Mixon. Thank you.
Thank you. I appreciate that introduction. Very kind. All right. So the title of my talk is When a Neuropsychologist Becomes a Parkinson's Disease Care Partner, because I am sort of in this unique space of having been a neuropsychologist for quite a while before I became a care partner. So I now have a better understanding, not just from an academic perspective or a clinical perspective, but also from a life perspective. And so that's what I'm going to share with you guys today. Hopefully there will be something in this talk that is useful to you. There we go. Okay, so just so you know a little bit about me, I was born the oldest of three girls to my parents. Both of my parents grew up pretty poor, but both of them worked really hard to provide for us, and we had a really good life, and I'm from West Texas. Dad had gone into the Army right after college, as many people in his cohort did. But he wasn't there long, and after he left the Army, he became an accountant because he had gone to college just before that, as I said. So he became an accountant and eventually the chief financial officer for a Coca-Cola bottling plant where we lived. He was there for 20 years or so, and then he became a finance professor. And then he got his doctorate degree. So that was pretty fun experience to watch. He went into graduate school right after I finished. So we had lots of conversations about doctoral work and the ins and outs of that. My mom was a stay-at-home parent for most of my childhood. And then when I was 16 or so, she became an administrative assistant at the same college that my dad was teaching at. And my mom, this is not about my mom, this talk is not about my mom, but she was an extraordinary person in the sense that she was easily the most organized human being I've ever known. And I learned a lot from her about that. Both of my parents were really involved in their community, their church, their neighborhood, community organizations, and so forth. Both of them had leadership positions in various organizations that they were in. And I tell you all this stuff because I want you to understand that my parents had high expectations for themselves and for us. So the two things that we learned more than anything else was always do your best, no matter what. The outcome can vary, but your best can't vary. And then also to always live with integrity. And so those are sort of defining principles for me, and they shape how I have kind of come to my career as well as my experience as a care partner. So as Dr. Sood said, I got a PhD in clinical psychology, and I got it here at UT Southwestern. And then I went, then I did a postdoctoral fellowship here. And following that, I went into private practice for about 8 years. And then when I'd had as much fun as I could stand in private practice, I came back to UT Southwestern, where I have been here for 19 years now. So those of you who are good at math will know that I am not a spring chicken anymore. I've had 3 specialties really throughout my career. So I started out in neurodegenerative disorders, so Alzheimer's disease, Parkinson's disease, Lewy body dementia, et cetera, vascular dementia, and so on. And then I kind of morphed into doing a lot because of a job I had. I morphed into doing a lot with traumatic brain injury and acquired brain injury. And that's when I really began to host support groups. That was probably 20 years ago or so. And I pretty much have done that continuously ever since. So initially those were with brain injury care partners and survivors. And then in the last few years, I've become more and more involved in a category of problems called functional neurological disorder, which again is not the point of this talk. If you want to know more about that, I'm happy to explain it, but it essentially is symptoms that look like neurological problems, but there's no medical basis for them. And so I have become increasingly interested in that and active in that area. So moving to the caregivers part or the care partners part, I wanted to real quickly just define the difference because most of my career, we have called the people who help take care of other people caregivers. And in the last few years, the term care partners has really come on. So what's really the difference? Well, I think they're often used very interchangeably, but actually they're different. So a caregiver is a person who provides help to another person, and it's more or less a one-way relationship. Somebody who is paid to take care of somebody else. It can be a family member, it can be whoever, but primarily it's a one-way helping relationship. A care partner, on the other hand, is actually a two-way relationship. So a care partner is a person who works with the person who may need help, but also they get some kinds of help, whether that's emotional or instrumental, which means things that the person does that can be helpful to them. So in this case, you see that there's kind of philosophically two different assumptions that are related to that. Most of the time, I'm pretty good about saying care partners because mostly that's what we are. If I slip into saying caregiver, then I hope you'll forgive me because I'm old enough to have to change after a long time. That's not as easy as it could be. Okay, so I want to real quickly kind of review information about what the burden for care partners is like. And this is just some factual information that you may already know. But about 90,000 people a year, Americans, are diagnosed with Parkinson's disease. And then about 1 million Americans currently have Parkinson's disease. And this is actually increasing, probably because people are living longer. And Parkinson's disease tends to occur in older adults. Most of the people who have Parkinson's are cared for primarily by their family members or their friends, mostly family members. And so I found a recent study that looked at care partners actually in 7 different countries, including the US. And they found that 70% of the care partners are spouses, which makes sense. 72% of them are female. The average age of a care partner for Parkinson's is 63 years old. And most of the other 30% that are not spouses are paid caregivers. So there really are very few actually friends or other family members who are taking care of folks who have Parkinson's. So primarily we're talking about spouses, mostly females and mostly older adults. The burden for any of you who are care partners on this talk, you know that it can be pretty real. It can be pretty heavy. And there are multiple areas that tend to be impacted by care partner activities. So physical health, mental health, financial health, social health. I'm primarily going to kind of focus on the first 2 today, but it's clear that those other areas are important as well. And so if you are going to reduce your care burden, then you really need to pay attention to all of these areas. As I said, I have more expertise in the first 2, so I will kind of focus on those, but all of them are important. And so to be able to stay healthy as a care partner, you really want to try to plan for as much as you can and remain open and flexible to changing your strategies as the disease progresses, as life happens, the unexpected or new things come about. So that's kind of the foundation on which I talk about care partnering. So I want to talk about my care partnering journey specifically, and then I'm going to shift over to some ideas about how care partners can best manage in this life that we have. So my care partnering journey actually began with my dad, the one that I just talked about. My dad and I were really close. He was diagnosed with mild cognitive impairment in 2005, and then pretty quickly actually progressed to Lewy body dementia. I don't think he was formally diagnosed until 2008. But during that time, the reason he even got diagnosed with MCI was because my mom came to me and said, "Hey, I think that there's something wrong with your dad." So mom was dad's primary care partner. They lived in New Mexico where they had retired. And then there was a health scare with my mom. And so shortly after that, they ended up moving to another place, which was in Wisconsin, to be close to my baby sister. And they did that a couple of years after dad was diagnosed. In 2012, dad moved to a memory care facility because it became difficult for my mom to take care of him. He was impaired enough at that point that it was really tough. And remember, I told you my mom was the most organized human I've ever known. She was a fantastic care partner. She did really, really good things for dad. Maybe a little too good, because there were times early on that he kind of resisted all that. But as he became more impaired, that was a real strength. And so she held off for a really long time. You can see for 7 years he was at home. Unfortunately, mom got cancer and then died within a few months, really. And that happened in 2014. So that meant that my sisters and I had to figure out what to do with dad, because he could no longer live at home. So the decision was made, because my baby sister traveled a lot with her work, that he would move down here, which is where he's from, but had not lived here for a while. So he moved down to Dallas-Fort Worth area, not too far from where I lived, and I became his primary caregiver at that time. And then he lived in a memory care facility until he passed away in 2017, and he was right at 77 at that time. So both my parents actually died pretty young. The important thing that I want to emphasize here is not the sadness of losing my parents, but what I learned from that caregiving experience, or that care partnering experience. With dad, it was probably more caregiving, honestly, because I kind of got the tail end of his illness. But I learned some really important things, and those are on the slide. So the first one probably was seared into my brain, is that good financial planning is essential if you want to have choices when you need care. So my parents did a fantastic job of this. They had everything set up. There was really nothing for us to decide other than which facility when Dad had to move down here. So they had all of that set up, which was an enormous gift to my sisters and me. I also learned that it was really important to be able to ask for help as a care partner. You might imagine that given the very independent and hardworking family that I came from, I myself have a lot of those same qualities. And asking for help doesn't come easy. So you're going to hear me say this a fair number of times because it was a really important lesson for me to learn. When your loved one is becoming more and more impaired, either physically or cognitively or both, being a care partner is probably the hardest job there is. And even if you have help, even if you have great help, it's still a tough slog emotionally. And there were many times that I drove home from my dad's facility with tears on my face. And if you don't have enough help, then it's even more difficult. It's practically impossible to do everything that you want to do in that scenario. So believe me when I say I understand how hard this job is. It involves a lot of grief because there is loss. There's loss before the end, and there is loss after the end, of course, of life. There's along the way, there's frustration, there's anxiety and worry about what's going to happen. But I also want to emphasize that there's joy. And what I learned is that if I take good care of myself and I focus more on the small things, I do focus on the future, but I also focus on daily little things that bring me joy. And that makes a huge difference in terms of feeling okay as I go through this process, because it is a tough process. There's no question. Now I want to switch to talking about my second care partner journey, and that was being the care partner for John. In 2010, which is actually when we started dating, he started experiencing a tremor in his left hand. And then 3 months after we got married in 2012, I got him in front of Dr. O'Sullivan here at UT Southwestern. And within about 5 minutes, Dr. O said, "Yeah, you have Parkinson's disease." Not the answer that we wanted. We were much, hoping that it was something else, but it is what it is. And it was a relief to have a diagnosis. John was really young when he was diagnosed. He was much younger than usual. So he had what's called young onset Parkinson's. He did really well for a long time. He started on medication right away. But eventually, his dyskinesias in particular, but also tremor and other things, were sort of not being well controlled by medications. And so we made the decision for him to undergo DBS surgery. And we did that this year in March of 2024. So since DBS, John is doing great, and hopefully he can speak to that a bit at the questions time. He still has limitations. He still has issues that, he would like to change, and I would like for him to be changed. But his functional capacity is much better than it was before. So at the top picture, you can see him playing pickleball in our senior Olympics that we had in last year, I think, in our neighborhood. He's an avid pickleball player. He walks our dogs on several times a week. He started playing poker with our neighbors, which is great actually, except for, you have to just only take the certain amount of money you can lose. And he's also singing with our neighbors, which is awesome. And he's joined the Parkinson's Voice Project a few times. He's also, and this is probably the most important thing in terms of my impact on me, is he has been able to resume taking care of our home. So he has been on disability for a number of years, about 8 years, I think. But he has been our stay-at-home person. While I go to work, he stays home, he runs the house. He has done a great job of that. And slowly but surely that was kind of falling off, but he is back to being able to make a lot of our meals, to clean in the house and all that kind of stuff. And that that stuff is enormously helpful for me. He's also volunteering in our neighborhood. He mowed our neighbor's yard a couple weeks ago. He bakes bread for an organization that we have that's helping each other in our neighborhood and so forth. So hopefully you're getting the picture that his life has been greatly enriched since he had his surgery. All that being said, that's all true. It's still stressful to be a care partner. And so I want to kind of, as honestly as possible, present what I have experienced in terms of stressors, and then we'll get to hear from other people. So the biggest one probably has been a financial stress, because John was 48 when he was diagnosed. He was 51 or 52 when he had to stop working. That we were not ready to retire at that point. And so he ended up on disability at a pretty early age. That, as all of you know who have been on disability, cuts your income more than in half. So it was pretty significant. He was able to work part-time because he had been a teacher. He was now doing part-time tutoring. He did that for a while as well, and then he became unable to drive. And so that part of his work life had to go away. And so the sort of take-home message here is, because we had this income reduction, we had to pretty quickly make some adjustments. So we had to downsize our lifestyle, which really wasn't that hard because we were pretty simple. But we had to make financial planning a bigger priority. And you would have thought that I would have been better at that just because of my dad's experience. But, you know, when you're young, you don't always notice all the things that you need to do. So this kind of brought it home in a much more clear way for me. There are social stressors too, partly because of Parkinson's, I think, and partly because John is just he's a private person. He gets really uncomfortable in crowded places. And in our neighborhood, we have big parties where lots of people, like 100 to 200 people, can show up. So there have been plenty of times that we've gone and left after like 30 minutes. So we tend to go early, just so that, you know, by the time that the whole party builds, we can bow out without, you know, missing too much of it. But that's one thing that's happened. Sleep is an issue for John, as well as many, many people with Parkinson's disease. And because of that, his physical energy and his emotional energy sometimes, and his willingness to be social can be impacted because he's just tired or he needs to sleep. There are also times when he just doesn't feel well enough to go at all. And then I have to decide whether or not I'm going to go by myself or I'm going to stay home. I'm a very introverted person as well, so as often as not, I stay home, but I have increasingly begun to try to go ahead and do things without him, because I think it's good for me. Emotionally, John does occasionally suffer from depression. It's happened 2 or 3 times in the course of his illness. And of course, when that happens, that always impacts your spouse. We are really fortunate that I'm a psychologist and I have connections to other people. So we've been able to find help for him pretty quickly when that has happened. And so that's been really good. But it's still an issue that we have to watch out for and monitor and then treat when it happens. And then probably a little bigger than that even is sort of the changes that have happened in terms of our planning together. John is perfectly capable of making decisions and planning and so forth, but he needs, and task initiation has become harder for him. So I end up making a lot of those decisions, usually in association with his input. But still, I'm the one who's actually doing the scheduling and the appointments and the, you know, insurance changes or whatever it is. And sometimes that can be a lot. I suspect that will become even more of an issue for me as time goes on. So, given all that, what do I do to take care of myself? And I do not present myself as sort of the standard for what all care partners should do. This is just my own individual, these are my choices, but I do think they're based in good research and clinical knowledge about what is useful for care partners. So starting with that old saying that many of you probably have heard, if you're not okay, then your loved one will not be okay. I believe that in my bones. You really have to take care of yourself if you want to be a care partner for very long, because otherwise you will crash and burn, physically, emotionally, some other way. So because I believe that so strongly, I really do make self-care a priority, and that has become more true over the course of the 12 years that John has had Parkinson's. So it started off not so much. Now I do a fair amount, as you will see. So in terms of physical health, I'm very aware that I need to stay healthy in order to be helpful to John. So I have very regularly seen my physicians. I see my dentist 3 times a year. I manage all my health issues as much as I possibly can. And right now that is working great. Hopefully that will continue to be the case. In the last several years, I've made some real changes to my diet to be healthier, and that has been useful. I exercise, and I say somewhat regularly because it kind of depends. Like 3/4 of the season of the year, I'm pretty regular, and in the summertime, not so much because my primary exercise is pickleball and walking, and I don't do well in the heat. But that being said, I still am very focused on the fact that I need to be moving my body. I also get massages every month, and I don't do that for relaxation. I've told you many times, this doesn't relax me in the least, but it does help with muscle issues and swelling and other kinds of things. And so I do that as part of my healthcare. And I understand that I'm really fortunate that I can afford to do that. Other people may not be, but whatever you can do to improve your physical health, do it. Emotionally, I also really pay attention to what those stressors are and how I can manage those. So I mentioned that I've been doing caregiver support for about 20 years. I no longer do it as a neuropsychologist. Now I do it in my neighborhood. And it's actually a care partner support group. And so I lead and I participate in that, and that's been really helpful. About a year ago, I joined a weekly meditation group, which has been really useful in teaching me how to stop and pause and clear my mind and slow my body down. I highly recommend learning how to meditate. It's really, really useful. Almost every day, I will watch YouTube videos. John can tell you about that because he's always like, "Are you watching another one?" And I also read almost every day, and that is part of my lifelong learning desire. That really feeds me emotionally to know that I am progressing in my knowledge about this thing or that thing, and it's a lot of different topics that I pay attention to. I also read just for fun. That is an important piece of what I do for myself emotionally. I check in with myself to make sure that I'm okay. I think this is something I only maybe in the last few years learned how to do, which is ironic, I know, for a psychologist, but because we're helpers like other people, nurses and social workers and so forth, we tend to really be focused on other people and not so much on ourselves. So I have learned how to stop, pause, make sure I'm okay. And if I'm not, to think about what I need. And then I didn't know whether this should go under physical health or emotional health, but I honestly think pedicures are probably emotional health. And so I do that kind of self-care as well because I like it and I feel better when I do it. Socially, I have made a much more concerted effort to do regular social interaction as well, because we know that social interaction is one of the most important things that older adults can do to take care of themselves. So I will regularly spend time with my people, my children, my grandson, a few friends that John and I have, individual friends as well as couple friends. And I check in with them by phone or we get together in person, really try to make sure that happens on a pretty regular basis. I really like spending time with John and we have fun doing stuff. He used to beat me continuously at Scrabble, and I'm happy to say that I can now beat him about half the time. So that's been fun for me. I don't know if it's fun for him. We also really like walking the dogs together, going to movies. We have a lot of different things that we like to do, playing pickleball together and so forth. I also regularly volunteer with that group that I mentioned that John is involved with as well. Part of my volunteering is the monthly caregiver support group. A part of it is I'm the chair of the respite care committee as well. And so this is a group of leaders in our community who get together every month, and we talk about how we can provide help to our other neighbors. And that's been a really good experience since we moved to our neighborhood. And then we try to participate in at least one social event a month, and maybe for some people that feels like not very much. For me, that's a lot more than I ever did before. So that's been really good. Our neighborhood obviously has parties and things like that we can do. And then the rest of that is kind of filled in with going to dinner with our friends or things like that. So all of those, I think, are really, really helpful. I've kind of artificially put them in different categories: physical, emotional, social, but they all kind of overlap and they're all important to me. Okay, I want to do this last part to just kind of talk about common struggles that care partners have in Parkinson's disease. Some of you may have some of these, some of you may have none of these, but I'm guessing that all of you have at least one of these things. So I want to bring that up. I'm going to start with early stage. So when you're first diagnosed or in the early stages of the disease, care partners sometimes have to deal with some of these things. So dealing with the shock of the diagnosis, I kind of alluded to that when John got diagnosed, even though that's what I thought he had, which is why I got him in front of a movement disorders neurologist, but I was still kind of hoping it wasn't that. So that's part of it, you know, kind of accepting the diagnosis, understanding what the implications are, all of that. Because I'm really committed to lifelong learning more about the disease and what we can expect and that sort of thing was really important. And other people have to do that as well. I have found that in the early stages, a lot of folks struggle to kind of find a good health provider for the person who has Parkinson's. And then obviously it's a never-ending process, but you have to make decisions about treatment on an ongoing basis. So those are struggles that sometimes newer care partners find difficult. Finding good help for non-medical needs is also really important. And so I'm talking about now the emotional impact, the social impact, financial impact, that kind of thing. For not just the care recipient, but also for the care partner. Early people have to also deal with what they're going to tell their family and their friends, and I might put employers on here as well. Like in John's case, he was employed at the time that he was diagnosed. So you have to kind of decide what you want to say to people, what you want to disclose, all of that kind of thing. In the event that you are working when you get diagnosed, or as time goes on, you're still working, then you may need to ask for accommodations at work. In John's case, there really weren't any accommodations that made sense because he was a classroom teacher and he couldn't just sit. He had to write on the board because he was a math teacher, etc. So that's why he ended up having to leave his job relatively quickly because there just weren't good accommodations. But many people are in positions where they can have some of those accommodations that work really well so they can stay working for a while. In terms of not just the early stages, but all along the way, I think that one of the biggest problems or challenges that care partners face, and I said that this was one of mine, is trying to go it alone, trying to do it by yourself. And sometimes that is because you as the care partner want to do it by yourself. And sometimes it's because your loved one who has Parkinson's wants you to do it by yourself. But as we said, care partnering is a burden. And I don't say that unkindly, but it just is added stress to your life in all of these different areas that are on the screen. So that's why it is not recommended at all. In fact, I would go further than that and say, just don't do it. Don't try to do it by yourself because it really is going to take a toll on you. And if you try to do it by yourself, it really increases the negative impact, I think. So the fix for that is to be willing to ask for help from other people, depending on what category that we're talking about that you're maybe struggling with, finding people that can be helpful to you in those categories. and really thinking carefully about what you can do in each of these areas, instead of just kind of going along and reacting as things come up. Like people with Parkinson's, care partners also can have their own emotional struggles. So sometimes these are illnesses like depression or anxiety. Sometimes they're just emotional responses like fear or sadness or hopelessness, things like that. You can have sleep problems. I know that there was a period of time where John's disruptive sleep was also disrupting my sleep. And so one of the very first things that I really paid attention to in self-care was getting my sleep under better control. So I go to bed earlier than I used to, things like that. Another emotional struggle that care partners can have is ambivalence. And we don't talk about this very much, but that is wanting to do something that's associated with care partnering and also not wanting to do it. And both of those feelings can happen at the same time. And when they do, it creates a tension that we have to figure out how to manage. We can also get pretty angry. We can get angry at a lot of different things, right? At the disease, at the person who has Parkinson's, at God, at other people who are not helping, at yourself for not doing it right or not being a good enough care partner. There's all kinds of targets for this anger. Some of them, may be kind of useful at times, but often they're not very useful. And we have to figure out how we're going to manage the anger. The anger itself is not the problem, it's what we do with it that can become issues for us. And then another thing that we don't talk about much as care partners is that you can have some kind of disgust or repellent kind of feelings about some of the things that you're being asked to do. Some people, for example, absolutely don't want to have to do the financial piece, and that just repels them to think that they're going to have to do that. Other people may be doing very intimate kinds of care with their partner, and that can be kind of gross, and they don't want to do that. So there's all sorts of ways in which we can feel disgust or avoidance, and we have to figure out what we're going to do with those feelings as well, or those can really eat at us. Other ones, embarrassment. We can be embarrassed at the way our care partner is behaving, or at their symptoms, especially if they're in public, or we can be embarrassed at our own uncertainty about how to manage that. I mentioned grief earlier, and I think that one's big and pretty universal. Parkinson's introduces a new thing, and when we were 30 years old, we really didn't think that Parkinson's was something we were going to have to deal with, most people at least. And so it impacts what we thought our life would be like, what we thought the future was going to be like, not just from when we were 30, but also when we were 60 and even 75. We still have ideas about what we think the future will be, and Parkinson's can really change some of that. There are also losses associated with being a care partner of a Parkinson's patient. Clearly, there are losses for the patient, but also the care partner has some changes and losses too. So one of the things that we are tasked with as care partners is to really try to maintain our emotional equilibrium, to stay steady, to stay stable. And so that gets threatened by our loved one's abilities and their needs over time, because those change, and usually not for the better. And so that also requires some flexibility on the care partner's part. We have to be willing to not just do things the way we kind of settled on them and they worked really well. We need to be aware that 2 years from now, we may have to have a whole different set of strategies because the old ones don't work anymore. And a lot of that has to do with the changes that happen in our loved ones. It can also be because of just life issues. You can have your own health issues or whatever it is that may get in the way. So flexibilities are pretty important cognitive skill that will help your emotional functioning. In the social realm, I kind of alluded to the fact that social interaction with friends and family can be reduced. That can happen for a variety of reasons, partly because your loved one doesn't want to do it anymore or can't do it anymore. partly because you don't want to do it by
Someone holds her
yourself.
accountable, and we need to hold her accountable in November.
You can actually be left out of social activities. You know, an example of this is this kind of funny one, really, but my son and daughter-in-law are big hikers. They are not going to invite John and me to go hiking with them, right? Now, that actually is because I have more trouble with it even than John does, just because of some hip issues. But it can hurt your feelings if family members who would normally invite you for something just don't invite you anymore. Maybe their perception is that you just can't do it, or it's too hard, or whatever, but then you have to deal with the fact that they didn't ask anymore. And that can really lead to loneliness. So those are things that we have to kind of think through and decide, okay, so how can we increase our social interaction, even if we can't go hiking anymore with our kids? Finding social activities that you and your care recipient like to do is really important. Both doing things together, that's really, really important. But also being able to do things separately so that you get your needs met, even if your care partner can't participate in that thing anymore. And then another thing that can happen is you lose people in your life, particularly if you have to stop working. If you retire or you stop working because you're taking care of your partner, that's a real loss. Even though those people may not be super close to you, the fact that you are able to interact with them on a daily basis really filled a need. And now that's not going to be there. So you have to kind of think through, okay, so I'm not going to have that now. What do I need to do to kind of fill in some of that blank? Because I'm still going to need social interaction. I kind of talked about a lot of this already in terms of what I do for myself, but a lot of care partners can struggle physically. And by the way, if those emotional things and those social things are not really paid attention to, the physical struggles become even bigger because we know that care partners' health can go downhill over time if they're not very proactive in terms of all of these categories in reducing their stress levels. So we can have negative impacts because we're aging too, because as I said, our mental health can reduce. We can have financial stress. There's a lot of things like that that kind of all boil down to stress. So it's really important that we don't put our physical health on the back burner, that we do not wait until we are sick to go seek help. We don't wait until we are struggling, you know, to walk upstairs before we go get an evaluation of what's going on with us. So we really need to pay attention to that stuff on a very proactive basis. If we're not exercising enough or we're not managing our diet well, that is a clear sign that we are going to be regretting that in the future. So those are important things to pay attention to as well. And then the last one, which is not very popular, but I think is important for care partners, is to prioritize is the fact that we often prioritize our loved one's health over our own. And that is a mistake. We need to, both of them are very important. So it's not just getting our loved one to the neurologist or to whatever other doctor they may be going to because they have this disease, but also for ourselves, whether or not we have any health problems of our own. The financial struggles, some of these are pretty obvious, but like I mentioned before, what we experienced, we had reduced income because John couldn't work anymore. A lot of care partners either cut back or quit their own jobs, or they retire also because it's really hard to take care of somebody and work full-time at the same time. That can be impossible in some cases. There are increased health costs for the person with Parkinson's. Now they need to go see a neurologist twice a year or more. They may have other things. And we ourselves also have increasing health costs the older we get. There's also an increased need over time for care services. So beyond what we can provide to our care partner, we may need other people to come in and help us for home health and that sort of thing, or even eventually to a care facility like my dad experienced. We can have unexpected bills for all kinds of things. So the cost of living, as everybody knows, has really gone up over the last few years. So all of that kind of stuff can can contribute to the stress that we feel financially. And then the last one is kind of what I also mentioned before, which is as a care partner, it can be stressful to assume most or all of the responsibility for the financial decisions, particularly if that's not something that you did in the past in your partnership. So those can all be areas of stress. So now we've talked about all the doom and gloom, all the things that are hard. I do want to just mention that there are joys as well. I said that a minute ago, but I want to follow up on it. It can be enormously satisfying to know that you are providing good care, you are contributing in a really important way to your loved one's quality of life as well. And so that satisfaction can really produce joy in your life. If you focus on it particularly and give yourself props for doing what you're doing, my guess is, like I have, that you will experience personal growth as a care partner. I mean, the pressures that come on and the burdens that you shoulder, those really create some positive personality characteristics, things like patience, being able to be persistent even when it's hard, and just learning how to be present. Again, that's kind of a shout out to meditation, which is only one way to do that, but a really useful one. So learning how to live in the moment, essentially, and not be so worried about the future or focused on what used to be. So we can develop more appreciation for the little things, and we can actively look for the blessings, the good things that we have in our life. All of that stuff, it's not just woo-woo stuff. That really makes a difference in how we perceive our lives. And so I think that all of these things are there. We just have to really sort of on purpose look for them. And when we do, I think that we get the benefit of that joy, which is great because we have enough stressors that we have to deal with. So some other areas or ideas about how people can find more joy. Obviously paying close attention to your own physical health. If you go down, it's going to be a lot harder to feel happy about that. Regularly talking to at least one other person, not counting the person you're helping to take care of. And to talk about care partners' struggles, joys, etc. Somebody that you can be really honest with. And talk about when it's bad and when it's good and so forth. There are a lot of different options for that. But making it a point to talk to at least one other person about that on a regular basis, every week, if at all possible. I think it's really helpful to make a list of things that would help you with your care partner duties. So if people ask how they can help, and chances are that has already happened to you, then you can think of something to ask them to do. This is something that we see in our neighborhood helping group a lot, is we offer to help and people say, I just don't really know what you can do to help. Well, if they had a list of stuff, like it would be really helpful if somebody went and got my groceries once a month. It would be really helpful if somebody could take us, my care recipient to the doctor once in a while. Whatever is on your list, then you have something that you can tell them about. I think that paying attention to the financial piece, which we haven't really focused on a lot, but getting a trusted financial advisor is really important. Looking over that stuff at least once a year, make sure that you're making the best financial plans that you have availability to do is really important. And then for free or almost free, other resources you can see on the slide, public resources like libraries and recreation centers and community centers and so forth. Religious organizations clearly can provide a lot of support for care partners. Interest groups like book clubs and museums and so forth. Online resources, so like Michael J. Fox Foundation, Parkinson's Foundation, Dallas Area Parkinson Society, all of those groups have online resources that you can take advantage of. Joining a support group for care partners, I highly recommend that as both a leader and as a participant. It is really, really helpful. It is not sitting around whining like some people think in a support group. Actually, there's a lot more laughing than there are tears, but people can be real with each other, and is really useful in healing to have that kind of a resource. And then you can also participate in Parkinson's research. Some of the people on this call already have done that, but I encourage other people, if you have any interest in that, This is obviously not for the care partners in most cases, although we would like to get more research like that done. But for your loved one, they can participate. And that brings you joy because you know that you are helping the next generation of people who are going to come along and also be diagnosed with Parkinson's. So my favorite Parkinson's patient, as you guys all know, it should be obvious by now, this is us at the Nationals Pickleball Championships in Dallas last year. We do really enjoy this game. I'm going to stop here. And I know I have some questions that have been sent to me, but I will let Anuba kind of decide what we do from here.
Thank you so much, Karen. This was absolutely wonderful. I'm going to open up the discussion to questions. We can probably start with asking, if you all have.
You're muted and
Okay.
Okay. Zoom issues always. Okay, so I'm just going to open up to questions now, discussion. If you have any questions, please come forward, unmute yourselves and ask. And of course, Karen has some questions as well that you all posted while you registered for this event. So we'll take those on if there aren't a lot of questions here. Maybe we start with a question, Karen, that you may want to tackle from the questions that were already posted, and maybe people will come forward if they have any.
Absolutely. All right, so I got four really good questions. So I'll start with this one, and then we'll kind of pause and see if anybody else has any questions. The first one was they would like to know more about how to help their husband with dyskinesia. I don't know who this was from, but I was right there with you this time, February. That was probably the biggest symptom, or the most troubling symptom, at least for me, of John's. I think for John, it was no picnic either. And so if you don't know what that is, dyskinesia is a kind of fidgeting or writhing or wiggling around in a fairly uncontrolled way. It's a side effect of long-term levodopa use. So it happens to most people that get Parkinson's. So it's a pretty tough symptom. I did look up a few ways that you can reduce dyskinesia. Some of them are maybe not great options, but I will throw them out there anyway. So the first one, the most effective one, is to reduce the amount of levodopa that you're taking. For most people, that is not a good option, because that means that their tremors and all their other Parkinson's symptoms get worse. And so they have a lot more off time than on time. So most people, that's not really an issue. That's not a choice they want to make. One thing you can do, though, is to make sure that the timing of the levodopa really matches the on-off cycle, so that you get it very consistent. If your on cycle is 3 hours long, you take your medication right before that 3 hours, so that you kind of have this continuous blood level. That is hard to do for a lot of reasons, but it is a way that you can help reduce some of the dyskinesia. You can switch to extended release versions of levodopa. Ritari is probably the most popular one. All of those extended release versions are pretty expensive right now, but they are covered by Medicare. If your loved one has Medicare, that helps. You can also increase or add, if you're not already on it, amantadine. And there is a new extended release version of amantadine. It's called Gocovri. It is very expensive. It's about $3,000 for 60 tablets or something like that, which is a couple months worth. But Medicare does cover that as well. So that's helpful. Then I would say, DBS is probably the most effective way to reduce dyskinesias, at least for now. in the short run for John. It's probably the primary symptom that has been reduced for him, which has been really, really helpful. They think that DBS helps with dyskinesia partly because of the stimulation and partly because you take less meds typically after you have the surgery. And so John, for example, has taken about half the medication that he was on before his surgery. So that really reduces the amount of dyskinesia as well. And then the last one, which everybody has more control of, is learning how to reduce their stress, because dyskinesia is made far worse the more stressed you are. And even feeling excited, which is a form of stress, but a positive one, can also kind of contribute to dyskinesia. So doing things that reduce stress, things that are fun for you, doing yoga or meditation or other activities that require you to kind of calm your mind and your body, that can be effective in terms of reducing dyskinesias as well. So I will stop with that for now. If we have other questions in that way, that would be great.
I have a question, Karen. If you could speak to us a little about, when we're looking for therapists, not just for our care partner, well, not for our, loved one, but as a care partner, what should we be looking for? How do we go about it? That's something that a lot of people, think about and just don't know where to start.
Yeah, absolutely. Somebody actually did ask this question also. So hopefully this will kind of overlap with that question about how you find a therapist. I acknowledge that it's not easy, and there's several different problems that are associated with it not being easy. Not the least of which is that a lot of providers don't take Medicare. So that's an issue. But that being said, I think there are some issues that you can do. First, I think being really proactive, you can ask your own primary care physician or your husband or wife's neurologist for a referral. And my personal opinion is a referral to a psychiatrist as well as a therapist at the same time is very useful. You may or may not actually need the psychiatrist, but having that evaluation can be really helpful. The psychotherapy part, there's a few things you can do. What I would look for more than anything is a person who has a master's or a doctorate in a mental health area, who has specific specialty or training in helping people with chronic illness. And so that's in psychology, that's a neuropsychologist or a health psychologist. And then there are a lot of other mental health therapists who may have some expertise in that area. Those tend to be hit or miss. But with those two types of psychologists, you know for a fact that they have training in those two things. So those are three different possibilities. The way you can look for those, if you have regular insurance, you can go to a website called psychologytoday.com. And unfortunately, this is, I'm putting a lot of work in your life if you do this, but you will get about 100 or 200 different possibilities for therapists. All of those, or almost all those people, say what they specialize in. Now, some of them have a list that's, this long. And so you don't really know if there's specialists in health, but if they say something like chronic illness or medical illness or any of that kind of stuff, that's the person that you probably want to start with.
I just want to pop in, Karen. I'm sorry.
Yeah.
I use Psychology Today as a reference too. What's nice is if you don't live in the Metroplex or nearby, you can plug in your zip code.
Yes.
And then that's going to pull out the people that's in your area. And that's really helpful. That kind of narrows it down.
I totally agree. Thank you. That's Connie, right? I can't see you.
Okay.
Yeah. It's a really good resource. It is a lot of work. I'm not going to lie. It can be frustrating to go page after page after page reading all this stuff, but it's still a good resource. If you only have Medicare, as I said before, that is a barrier for sure, because Medicare doesn't pay well for mental health. So a lot of mental health providers don't take Medicare. So what I would suggest, even though Medicare does pay for psychotherapy and psychiatry, so what I would suggest is look at the medical centers around you. UT Southwestern, our multidisciplinary psychiatry clinic, they all take Medicare. Baylor has, that's a big system. They have Medicare. Texas Health Resources is a big system. Look for the big health systems because they tend to have, they tend to take Medicare, at least some of their providers do. Sometimes all of them do. In Fort Worth, John Peter Smith is another big system that you can tap into. And you can just go to these systems websites and kind of sort out like which hospital is closer to you and what, if they have these services. I also want to make a plug for MHMR. Mental health, mental retardation is a state-run, county by county service that people have. The wait times may be a little bit longer. They tend to be low cost. They all take Medicare and Medicaid. But you can get some good care there. So that's something to really consider. Again, if you don't know how to access those systems, ask your doctor. But you can also just kind of Google it. Get online and Google mental health, MHMR, Tarrant County. And you should get information there that can kind of help you with that. And lastly, I want to mention that Total Care is actually working on this. I know, Anuba, you can speak to this much better than I can, but we're planning to put mental health provider in the movement disorders clinic, which is going to be really useful. So that's an upcoming resource. That one's not available yet, but it will be in the future if you get your care through UT Southwestern. So those are my ideas, Connie, or anybody else on the call that has other suggestions. I would welcome your input.
Well, I can give out the Family Studies Center phone number. Now, we are in operation on Tuesdays and Wednesdays, and we take cases till 7:00 p.m. And so that number is 214-648-6945. And I think we may have a couple of openings right now, but they keep us busy. But it is another alternative. And
Absolutely.
And we also try to redirect people to other resources if we need to. So, yeah.
Thank you. I just forgot to mention y'all, but I know about you.
Yeah.
If you are interested in the multidisciplinary psychiatry clinic, which I am not part of, but I work with those folks a lot, their number is 214-645-8500. You can directly contact them. I think you need a referral. I think you need your doctor to send them a referral. So that can be either a doctor at Southwestern, which is ideal, or a doctor outside the system can also refer you. And that gets you to see a psychiatrist and also a therapist if needed.
I'll put these resources in the email that I send after this conversation, but also please reach out to us, to the Total Care Program, either on my email, on Janice's email, or we also have OBI Total Care Program at UT Southwestern. If you write to any of these, we will be more than happy to give you the resources that we know of. We'll be able to help you sort of look through resources if that's the kind of direction you may need. So please reach out to us for any of that.
I'm just looking at the chat. So Marianne, you sent me a direct message. Absolutely. I will give you a call or I will email you probably, and we'll set up a time to talk. Do you want me to talk about some of these other questions?
Yes, let's do
okay. So two of the other two questions that I have, one says, I have a pastor that recently disclosed his Parkinson's disease, and I mentioned deep brain stimulation, but that it was his personal choice if he didn't want that, and you could live a full life with the diagnosis. What advice would you give to skeptical patients, friends, caregivers, members of the medical or religious community that do not believe in DBS? So I thought about this a lot because it's a good question. I could only think of 3 faith-based reasons why somebody might not want to have DBS. So feel free, if you're on the call, feel free to add to this. But I thought if you're a Christian Scientist, because they actually, part of their theology is that they believe that healing should come through prayer. And so they don't seek medical help in general. If you're a Jehovah's Witness, they tend to avoid surgery because of the potential need for blood products. So that's an issue. But I think probably the most common might be that some people of faith believe that God is going to heal them from their Parkinson's. And so if that's their belief system, they might see surgery as a lack of faith in some way. That aside, assuming that it's really not faith-based, there are a lot of other reasons that people don't want to do DBS, right? The first one, and in some cases, I'm being self-revealing here. It's scary to think about somebody putting some leads in your brain and to hook them up to a simulator and that you're going to get, zapped essentially on a regular basis. That's pretty scary for a lot of folks. As John mentioned, it took us probably 2 or 3 years from the time his neurologist said, hey, you ought to think about this, to when we said yes. And I say we because it very much was a back and forth discussion that we had. And I admit that I was a no at the beginning, because being a neuropsychologist, I'm not a big fan of brain surgery. That being said, the more I learned, and so I would say educate yourself about this, the more I learned about the surgery and the more both of us kind of learned about what the outcomes had been and all of that kind of stuff, the better option it looked. And so we eventually said yes to that. But I think being educated was key. Had we not done that work, I think we probably would have continued to say no. I also think that we had to just kind of come to terms with what the most likely symptom relief would look like. What was going to be impacted, what was not going to be impacted. That's part of educating about the procedure, but it's also about what the life looks like after. And so I think that those things were really important for us, at least, to decide that the benefits outweigh the cost. And I think many people may go through a similar kind of process. I think another thing that's kind of scary is that DBS is major surgery, just in general, right? In fact, if you get it at UT Southwestern, it's 2 major surgeries. And so you are under anesthesia. There's risk associated with that. There's risk in the surgery, all that stuff. You have to sign all that stuff before you go in. And so I think you have to decide that it's worth the risk for you to get the kind of benefit you want. And then also DBS now means you have something else to manage. Like in John's case, he has this rechargeable simulator, which is awesome. But also it turns itself off every 50 days, which we just learned about. And so now we have to track that. Now we have to just plan for, okay, on, September or whatever, it's probably gonna turn off. So the day before that, we need to charge it up. Things like we have to check the phone, make sure it's on. If he walks in and says, with tremoring going, I think maybe my stimulator's off. That's happened to us already. So it's just something else to kind of think about and manage. You have to recharge the thing every 3 or 4 weeks. So there's a lot of good things about having this particular system, and that's why we picked it. But also there's more to manage. There are other systems where you don't have to do that, but then those are less, some of those you can't have an MRI ever again if you do that. That may not be a big deal for some people, but for some people it is. I mean, what if you wreck your knee and you need a scan? So yeah, there's just stuff like that you have to kind of think about. I think for us, having some kind of a sense of denial was also something we had to work through. So when we first did, I was like, I don't think so. Partly because of fear of putting something in your brain, but also because we felt like, I'm not really bad enough yet. There was that. I call it denial because our neurologist was saying, yeah, you are. But, we didn't feel like the cost was that high of not doing it yet. And so when those evened out, then we were willing to do it. So I don't know if you would call that denial or really just a rational assessment of where you are, but either way, that can be something you have to kind of work through. Other things to just know, DBS is not really recommended typically for people who have not had Parkinson's for at least 4 years. They have to have been responsive to levodopa while they've had their illness. They also have to be having big motor fluctuations. The on-off thing has to be a big change. Those are the kinds of criteria. So somebody who is early in their Parkinson's disease may not have experienced all that stuff, and they're not even candidates yet. So that's just something when you're talking with folks who are earlier in the process, it may not be something to even talk about with them because they're not ready. They're not candidates yet. But even if they are, then it may take a while for them to kind of come to terms with it. So those are sort of my advice pieces, I guess. Don't really bring up DBS with newly diagnosed folks because, I mean, you can talk about it, but chances are they're not going to really want to do it. You know, they're still trying to figure out how they're going to live their life with Parkinson's, let alone think about major brain surgery. Educate other people, educate the people that do bring it up to really know about DBS, to know what the facts are, and those are going to change over time, right? Because they get new technologies and things like that. So really understanding what they need to know, because there's a lot. And then if they're dead set against it, you mentioned that the pastor was like, if they're just, then, you know, if they're against it, let it stand. It's their life. You know, all of us get to choose for ourselves. Having DBS may not be the best option for everybody, for whatever reason. And so just being respectful. I'm not suggesting that whoever asked this question was not being respectful, but I think we have to, even if we bring it up, you know, it's more like, here's something I've heard that helps, you know, you might want to check it out. That sort of off, you know, not pressuring people in any way to really think about it or whatever. I think giving people time is really important. So I don't know if that helps.
Thank you. No, it helps.
The only other question I got, which is a huge one, which is how do you address a care partner that you know is struggling with their loved one, in particular with placing their loved one in a facility or hiring in-home healthcare? This is the big kahuna of questions for people with Parkinson's. So I very much understand the question. I'm not there yet, but I will be. And so, yeah, I appreciate the question. So by now you guys should know that I am a big believer in aggressive self-care for you, as a care partner. So that's first, that's step one. Before you start making other decisions, make sure that you are okay. Make sure you are taking care of you. Because even if your care partner y'all get help in home, or you put, you know, your loved one goes to the facility, you still need the self-care. So make sure you do that. But in terms of the actual question about what to do, I think, again, education is really important. I think, and I'll put myself in this category to some degree, we don't know enough of the facts about in-home healthcare, having people be in facilities, whether it's assisted living or memory care or nursing home or whatever it happens to be. Most of us, and I'm even, you know, I'm a professional, I should know more of this stuff. I don't even know all this stuff, right? And so I think that before you make a decision, you really have to educate yourself about what the options are. Focus on everything that you need to know. So not just how much does it cost, right? That's huge. But also, what do you get for your money? I mean, that's a really important question, right? Is it going to do enough for you to have an in-home health care worker? It may very well be all you ever need. But on the other hand, it may not, right? It may be a short-term solution, and you have to be okay with that as well. Will having help in your home for whatever the help is, will that delay getting your loved one into a facility for months or years? If so, that may be a much better first step. Most of us want to age in place. That's the term now for staying at home and getting the kind of help you want. So often people are considering in-home care first. On the other side of that, for the care partner, I think you have to ask yourself, what are the signs that your loved one needs more help than you can give, right? And that is a hard question to answer because most of us, like I said, have this independent streak and it's like, I can handle it. Sometimes we cannot, and we need to be real clear about at what point, you know, what needs to happen before I say, okay, I need help in this particular way. So I think that, you know, changes in your loved one's health, changes in your own health, both life changes, all of those things may play into that decision about whether or not you seek that care. And then obviously you have to know what your options are for paying for it, because it is very expensive, as pretty much everybody knows if you've even spent 5 minutes looking at it. And there are options: long-term care insurance, veterans, what's it called? There's a care facility for veterans. They do respite care and they do long-term care. There's different things, but you have to kind of educate yourself about that.
Karen,
And then what I would say,
hi, I'm sorry, Karen, this is Connie. One of the things that I learned from working with the ALS population is that often people found good in-home caregivers by talking to other people who utilize that agency or that particular group. So ask people who've done it or who's about to do it or who's doing it to get recommendations, because that's how a lot of people networked and found some good in-home care.
yes, that's a really good point. I actually have a friend who did that very thing. Her husband actually had brain cancer, but she needed some help. And so she just asked around and found out that a friend of hers whose husband had just died had this caregiver, and they called her.
Yes.
And she was available. So that worked out really well for them. Other people would prefer to go through an agency. It's more expensive, but if the caregiver goes down, if they get sick or they're get a flat tire or whatever happens, the agency can send somebody else. So
Or even checking with other people who are using agencies, because there's some agencies
that too.
that people have had good, good outcomes and others who haven't.
That's a really good point. Yeah, they're not all created equal. Some are better than others. That is for sure. I would say that if you're sort of at the point where you think that this is going to come up pretty soon, that you need to ask for help, and ideally it's objective help. So not your kids, not your family. Those people have skin in the game, right? And they can be very, very useful in helping you kind of think through stuff. I'm not saying don't talk with them, but I'm saying before you decide, you may want a sort of objective person, a doctor, a social worker, somebody else that can kind of help you walk yourself through all the things that you need to know before you decide. So I would start by asking, again, your primary care doctor or your neurologist, ask them for help. It can be a volunteer. They may know about volunteers in Parkinson Foundation or something that would help with that. It might be a mental health provider. It might be a caseworker, a case manager, that kind of stuff. I will tell you that most for-profit insurance, so we're not talking about Medicare, but all the others, Blue Cross and Aetna and United and so forth, all of them pretty much have case managers that they employ. So you just have to ask for it, and they can help you with that. The Veterans Administration also has case managers and social workers that are available if you are a veteran or your care recipient is a veteran. And then something I've recently found out, which I think sounds really awesome, but I don't have any personal experience with it yet, is something called the Patient Advocate Foundation. They offer free individualized case managers for people who have serious health conditions who are in active treatment. So that would pertain to almost everybody on this call who has Parkinson's, I'm guessing. I have the website and I have the phone number, but they can help with things like getting medications for less money, managing bills, choosing insurance stuff, all the things. I mean, it sounds phenomenal actually, and it's free. So I don't know where the source of their money is, which might be something you care about, but it's called the Patient Advocate Foundation. And I don't think they're in Texas, but they operate in the whole United States.
If I may
I'll just
add-
stop with that.
Okay, thank you, Karen. This was so helpful. I just want to add here, the Parkinson's Foundation, which is a national organization, they have a helpline, and that helpline is absolutely wonderful. I know personally of people who've used it and found a lot of great resources, and it's really about asking any question that you may have pertaining to a Parkinson's disease and resources thereof, and they'll be able to help. So I just wanted to add that, and I will add that piece as well as the Patient Advocate Foundation to my email that I'll send out as well after this. Thank you so much, Karen, for sharing your brilliance, your expertise, and your personal experience. With the burden, the struggles, the joys. And I really, as you were talking and I was listening in, I was really thinking about how, we want to absorb all the expertise and all the medical information and all of that. But, I really hope that the Total Care program is able to also do the other piece, which is connecting people to the resources that they need to live well with a diagnosis such as Parkinson's disease. It's a chronic disease. It requires so many things, and you spoke to all of that, right? The emotional, the social, the financial, and we're hoping that with your help, John and you are such gifts to us in the Total Care program, giving us direction, Connie here, and all of you really, people who are coming to these events and conversations. We want to hear from you. Give us feedback. Tell us what more you want. And we're right here, getting ready to offer those kind of connections and resources to you. Next, we will have the Dallas Area Parkinson Society come speak to us on September 13th about more resources that you can access in the Dallas area. I also want to talk a little bit about what Karen spoke about earlier about, home care and all of that. We have a neuropalliative expert here at UT Southwestern who will also be coming to speak to us along with her team of social workers. So, that's another great resource. All of these conversations are being recorded. They will be available on our website. And with that, I want to thank everyone and conclude this session. Karen, thank you again.
Thank you. I really appreciate the opportunity.
Thank you. Bye.
Bye.
Bye.